Okay, so this is chapter 13. Next week we will do chapter 14. The following week we will do chapter 15, and then we'll be done, which will be perfect because we'll be out of class periods anyways. Chapter 13 is, again, I mentioned this a little bit earlier, is pharmacogenomics, and let's proceed to talk about some of the key terms from this chapter. So, title term, but we need to take a minute to define this. So pharmacogenomics, and it really looks at two things. One, how do we design pharmaceuticals specifically for how the genome works, right? Rather than just designing them for some enzyme, why not design them for the gene that gets transcribed and then translated into that enzyme, right? Because if we can control the expression, we might be able to alter that protein before that protein even shows up, right? And so that's a really nice opportunity that comes from pharmacogenomics. It's like, instead of trying to figure out what to do with this mutant protein, why not just ensure that mutant protein doesn't show up in the first place? Okay? And so genetic engineering would fall under this umbrella of pharmacogenomics. For the most part, that happens very, very little in humans for now. And we'll see how that progresses over the next couple of decades. But it happens a lot inside of other organisms, and that would fall under the umbrella. So that's one thing pharmacogenomics tries to do, is to take information about how the genome functions and target pharmaceuticals for that. Okay, and then you could also target sections of the genome that are entirely regulatory, that never end up being translated into a specific protein. And then the other area of pharmacogenomics is to try to predict and anticipate how a pharmaceutical is going to impact a very specific individual with a very specific genotype. And so this other area of pharmacogenomics is basically exploring the reason why people respond to pharmaceuticals in different ways. Why does one drug work really well for one person and not well for someone else? Okay, and we'll talk about some specific examples. The textbook, I think, does a good job in this chapter talking about mechanism and not as much specific examples like chapter 12 did. This talks a lot about mechanism and gives you a few examples to highlight these mechanisms. Yeah, see.
I wonder, given the whole pharmacogenomics, do they also take into consideration mutation or like those sequences in the genome that would make pharmaceutical drugs?
Oh, sure. Yeah.
For some people that they would potentially become addicted to?
Yes, absolutely. Yep, that is another application of pharmacogenomics. All right. Next term we need to talk about efficacy. So efficacy is basically the effectiveness of a particular pharmaceutical. So it's how well does it work the way it's intended to work. And what you find is efficacy it's a variable. It's the way in which a pharmaceutical works varies from one individual to another, okay, due to genotypic differences. Primarily. There are some other differences as well. We'll talk about that in the coming slides. Not all of the differences in response are due to differences in genetics, which should be obvious because, some of it's going to be due to different environments, right? Some drugs are going to interact with what you eat or with other drugs that you take or with things that you've done in the past. And but efficacy, you need to think about this as a variable, okay? And so you can have a drug highly effective for one person, highly ineffective for someone else. Toxicity. So toxicity is a measurement of the degree of pathology caused by a pharmaceutical. So toxicity, measurement of the amount of pathology caused by a pharmaceutical. And this you also need to think of as a variable. Okay? The toxicity of a drug is going to vary from one individual to another. And a lot of that is going to be due to genotypic differences among individuals. I almost said between individuals, but that would only work if there are two. If there are more than two, it's among individuals. Sorry.
It's part of like when you're watching drug commercials, how like they'll have all the side effects listed.
Yes.
So like someone might see that, but another won't.
Right, yeah, you should never anticipate that you're going to get every side effect. I mean, that would be really unlucky. But yeah, I mean, yeah, those tend to be, reserved to specific individuals. And a lot of it's going to have to do with genetic differences among individuals. Adverse drug response. So this, this term, and when you see this term, you're going to immediately think pathology. And I don't want you to think that. When you see this term, you need to think something other than intended. Okay? So an adverse drug reaction or an adverse drug response is a response by an individual that is other than what you expect. Sometimes that might actually be a beneficial response, but we would still consider it to be an adverse drug response, even if it is beneficial. And you're like, how could you have something other than intended be beneficial? And so I'll give you an example. So there are a number of drugs that were developed to regulate blood pressure, but have an unintended response in helping to treat migraines. And so they were developed to actually lower and moderate and regulate blood pressure, but they actually do a pretty nice job of working to help regulate the amount and the severity of migraines. Yeah.
But are those connected?
Oh, sure they are.
If you have too much pressure in your brain, it can create a migraine.
Yes, they are connected.
That's not adverse, is it?
If it's other than intended, then yes.
It's like saying, like, I have a broken leg, so I fix my leg, but now I'm adverse because I can run. It's like, yeah.
I mean, here we're talking about separate phenotypes. I don't know if we would consider the ability to run as a phenotype. Maybe we would. I don't know. Maybe it is. Maybe your analogy does hold up. All I'm telling you is, I mean, if there's, but that's going to be true for any adverse response. Like, the reason you're going to get that response is because they're connected physiologically. Right? I mean, because otherwise you wouldn't have one of these unintended consequences. The reality there is it's just an unintended consequence of the drug. Yes, there is a connection between high blood pressure and migraines, but it's not that high blood pressure causes migraines. It's like you can have high blood pressure and never experience a migraine in your entire life. You could have migraines and not have high blood pressure, right? So it's not like having high blood pressure causes migraines, but of course they're connected and they're related, because otherwise that unintended consequence of the pharmaceutical wouldn't happen. So,
Is it other than intended or other than expected? Because if you expect certain
it's probably better to be thought of as other than intended, although because other than expected, I mean, when these drugs go through, by the time they get to human trials, a lot of the side effects you already know about. Right, because those side effects have shown up in your animal trials. And so you expect them, but they still fall under the category of adverse responses, even though you do expect them, but you don't intend them. That's not what the drug was designed to do, but it happens, right? It happens. And then, because like you listen to these drug commercials and you're like, wow, the side effects are way worse than what you're treating. And that's because you shouldn't anticipate having every side effect. If you do, then yeah, it's absolutely worse than what you're trying to treat. But if you just have one of them, then it's like, well, maybe it's worth it, right? It depends on how severely your life is impacted by whatever you're trying to treat.
But
Yeah.
sometimes the side effect is literally death. So
I mean, we're all going to die. We are all going to die. That's what I try to explain to my wife when she tells me I shouldn't eat Taco Bell. Like, Jordan, we're all going to die. Some of us at a younger age than others, and some of us in unintended ways, but we are all going to die.
We'd have a Taco Bell night.
I mean, I'm not opposed. I'm never opposed to a Taco Bell night. All right. Ethnic specific drug response. And so it is understood that there is a relationship between genotype and response to drugs. And some of these, and so this is a term that the author of this chapter is pointing out to where basically saying that this term is misleading. Okay, this term is misleading. Very rarely do you have something where it's like, okay, this ethnic group is going to always respond to the drug in this way, right? Usually what you have is that in certain ethnic groups, you have certain genotypes that are more frequent, and those genotypes cause you to, respond to the drug in an adverse way, okay? It is very rare to find something to where you have like a certain ethnic group that are the only group that have this genotype that correlates with a altered response to the pharmaceuticals. So the author of this chapter pointed this out to just say, it's not that simple, and this is a term that you should not use, okay? But then, one page later, they said African Americans are more likely, or they actually said people of African descent, the authors from Europe, but then they talk about the FDA a lot, which is an American. Anyway, sorry. But they said people of African descent are more likely to have this genotype, and this genotype correlates with this response. So that's the way you should deal with it properly, even though they got a little bit close to doing something that they suggested you shouldn't do. But again, you have to always refer back to like a very specific genetic marker. And while some genetic markers are more common in some ethnic groups than they are in others, it's very unusual to find a marker that is exclusive to a specific ethnic group. Human populations are just way too connected for that to happen very often. You're like, well, what about these, reproductively isolated groups? Well, that's a different story. And they're actually, they're by, anyway, sorry. I was going to say they're arguably a separate species, but that's another conversation for another time. I don't know if we're ready to handle that one yet. I don't know if I'm ready to handle that. Dana.
So would sickle cell be an example of a very specific genotype?
Yes, and that it's more common in people of African descent, but it is not exclusive to people of African descent. Sure. Yep. All right. Now some fun terms. You're like, Dr. Engel, all of these have been fun. I don't know what you're talking about. Pharmacokinetic. So the next three terms are all going to deal with mechanisms for adverse reactions to drugs. Okay? This one and the two following. Pharmacokinetic, the best way to think about this is an adverse effect because of how your body responds to the drug. How your body treats the drug and you're like, what do you mean by that? It's like if your body treats the drug the way it should, which is as a foreign material that should be detoxified, right? That's normal. If your body treats the drug as something that's not foreign and doesn't detoxify it, that's abnormal, okay? And bad. You're like, well, it's kind of weird to think about, but I guess it's true. Like the other thing I told you a couple classes ago when like the whole purpose of medicine is to keep you alive long enough to die from something else. And you're like, wow, it's kind of true, but sad, depressing. Do I even want to go into medicine anymore? I don't know. I'm not ready to have that conversation with you either. If you want to have that conversation, we can have it, but I need some time to fast and to pray. So, yeah. Okay, so pharmacokinetic, again, the best way to think about this term is it's basically adverse effects because of how your body treats the drug. What does it do to the drug? Okay, pharmacodynamic, the best way to think about this is its adverse effects because how the drug treats you. And you're like, wow, this is kind of weird personifying the drug, but I like it. Okay, so pharmacokinetic, adverse effects because of how your body treats the drug. Pharmacodynamic, adverse effects because how the drug treats your body. we'll talk about this in specifics. So then you're just, like, it's no longer these umbrella terms anymore. You're like, okay. So we'll put it in context, but we got to get to that slide first. Idiosyncratic. So idiosyncratic, these are adverse effects because of gene-gene interaction. These are adverse effects from a drug because of gene-gene interaction. It's not that your proteins are treating the drug in a certain way, right? As like not treating it as foreign or doing something to it with it that it shouldn't. Or it's not that the drug is modifying the target molecule in a different way. It's because there's some kind of gene-gene interaction going on to where maybe you are overexpressing or underexpressing the target of that drug. And so you have another like completely unintended, consequence because of a separate gene for you that you have, the non-target. Another way, so the gene-gene interaction, it could be a separate gene modifying your expression of the target gene. Or another thing that would fall under idiosyncratic is the drug does what it's supposed to do to the target protein or the target whatever it is. If it's a drug that actually modulates the DNA, that's rare, but you can find those. But if the pharmaceutical is doing what it's supposed to the target, but that for some reason modifies the expression of a separate gene, that would also fall under this as well. Idiosyncratic.
So the first thing you said was there's another gene that affects the gene that we're trying to target.
Yes.
And then the other one was the gene we're trying to target also affects something else.
Yes. Both of those would fall under gene-gene interaction. And both of these would fall under idiosyncratic if you have an adverse response due to gene-gene interaction. Because another gene is modulating the expression of the target gene, or because the target gene is modulating the expression of a second gene.
Do you have an example of that?
Yeah, I could think of one. Give me a moment. When we talk about this in a little bit of context, in a few slides.
Oh, I can wait for that.
Yeah. Can you? Or you can't?
I'll be okay.
Okay, thanks. And then the last key term, CYP, gene family. CYP stands for cytochrome P450 gene. And it codes for a machine that oxidizes materials. Okay, it'll oxidize endogenous materials, which come from yourself, and it will oxidize foreign materials as well. And so this is a gene that mutations in this gene account for something like 80% of all of the adverse reactions to drugs that have been attributed to genetic factors. And it's because, again, this gene, so it's a gene family, but the CYP gene family, they code for proteins that oxidize materials, which basically destroys them. So they are machines that are part of the metabolism of, breaking down these pharmaceuticals, whatever they are.
You said adverse reactions from gene-gene interactions?
Yeah, for idiosyncratic.
This wouldn't be for pharmacogenomics because it's how your body's treating.
Well, pharmacokinetic it's specifically dealing with the metabolic processes. So, like where you can't, it's not a target. It's not the target of the gene, and it's not like something that you didn't anticipate being associated with the drug. So it's not the target of the drug. It's not something that you anticipated being part of the metabolism of the drug, which would be like some of the genes in the CYP family. It's something that you completely didn't anticipate at all. Those would fall under idiosyncratic, if that makes sense. So idiosyncratic, these are going to be where you have a gene-gene interaction, where the second gene, either the one whose expression is modified by your target protein, or the one that modifies the expression of your target protein, okay, this is related to your gene, is something that you didn't anticipate being impacted by the pharmaceutical. Maybe you should have, but the reality is we still don't understand the regulation of gene expression very well. I mean, we discover new genes that are involved in the expression of other genes all the time. And unfortunately, it's usually as a result of trying to modulate the expression of a gene, and then you see how that ripples through the organism, because these genes are really highly connected. So let me. So I'll give you an example of. I don't know if you would call this. It would not be an idiosyncratic, which is what you really wanted. Maybe it would. I don't know. I'll give you an example, and you can do with it what you want. Okay. So one of the main ways that you treat HIV, and you keep people that are HIV positive from developing AIDS, is you give them something that basically destroys reverse transcriptase. Okay? And so HIV is a retrovirus, and so in order to finish its life cycle, its RNA that it injects has to be written back into DNA and then expressed as human RNA and then translated into basically human versions of the viral protein. Well, and that's all there really are, because viruses can't make their own protein anyways. Okay, and so that's one of the main ways we treat this, is we basically do something that destroys reverse transcriptase. Now, one of the consequences of that is, yes, it keeps you from developing AIDS. The virus can't replicate efficiently, and so you don't get AIDS. You remain HIV positive. But an unintended consequence is it basically shuts down the mobile genetic elements, what are these transposons. So you have what are called copy and paste transposons that get written into RNA, then reverse transcriptase writes them back into DNA and inserts them somewhere else in the genome. And so it basically shuts that down. Now, there's not a lot of that happening in the human genome, but there is some. And so that's an unintended consequence of this, of the treatment for HIV. So I don't know if you would put that under, it would definitely fall under an adverse reaction or an adverse response to the drug. And it would probably fall under idiosyncratic, because it doesn't really fit well with the pharmacokinetic or pharmacodynamic. Yeah. Okay. Yeah.
I'm still caught up on how the CYP gene family, how that isn't considered
This is not a separate. These are the three different mechanisms.
Right, but you said that it's responsible. Mutations in this gene account for something like 80% of adverse reactions, and you said idiosyncratic.
Did I?
It's a gene.
Oh no, it is pharmacokinetic. I don't know why I said that. I should not have said that. Yeah. Now I'm confused, and I confused you, and now I'm sad. I'm not really sad. I lied.
So what would be the phenotypic results of not having transposable elements? What do they do?
It's an excellent question. They don't do a lot. They do sometimes play a role in modifying the genome in a particular cell line. And so you'll see some cell lines that are a little bit different than other cell lines, because during your development, one of these transposons moved into a gene and basically shut it down. And so later on in life, these transposons are not super active, at least as far as we know in the human genome. So what would be the phenotypic results of that? Probably nothing. But what would be the long-term results of it? I don't know. Yeah.
So it only really affects for kids?
Maybe. Or maybe no one. Yeah. I don't know if you'd pass on the drug that's shutting down reverse transcriptase, because it's just targeting the protein. It's not targeting the gene that makes that protein. Yeah. All right. So what are the goals of pharmacogenomics? We talked a little bit about this already, but we're going to remind ourselves of these goals and basically give ourselves a little bit more information about how we do this. First goal, develop new pharmaceuticals. That's one of the two goals of pharmacogenomics. Honestly, it's a goal that is very, very difficult to accomplish. Anyone have any ideas of why? Don't look at these yet. We haven't talked about these mechanisms. Just this. Why is this goal of pharmacogenomics so complicated, at least in this country? Yeah.
The process takes forever.
Yes, the process takes forever to get a pharmaceutical through all of the processing, and it is super expensive and very risky, and so pharmaceutical companies will usually only take things through the process that they know are going to make them ridiculous amounts of money, right? And so what that means is that any pharmaceutical that you could develop for something that is a very rare illness that very few people are going to have, or is an illness that tends to only happen in people that don't have a lot of money, it is never ever going to be developed, no matter how easy it is. That's just the reality. It's how it works. No matter how easy it is to develop, or no matter how sure of a bet it would be to get through the entire process to be able to go to market, if there's not an enormous amount of people with money willing to pay for it, it does not matter. Because it just won't happen. And so that's why this first goal of pharmacogenomics is incredibly complicated. So they gave some numbers in the text that there are only about 35 to 40 new drugs that make it to market every year. 35 to 40. And yet, then we talk about some of these mechanisms. So these pharmaceuticals, they can target genes. You could target the actual DNA with these pharmaceuticals. You could target RNA. You could target the protein products. There are approximately 2 million different proteins made from the 2% of our genome that gets translated into protein. And right now, the number varies, but there's somewhere around 400 to 500 pharmaceuticals that are at market, that haven't kind of fallen off, and now you can get over the counter. Wow. And then with the fact that we can basically, I could theoretically design a pharmaceutical that is specific for you, that will only work for you and will work for no one else because of your specific genome, right? We could do that. And it's not only is it theoretically possible, but it's not even that complicated. And then knowing that we only have obviously not all 2 million proteins made in the human cell are going to have any value to design a pharmaceutical to modulate that protein, right? Some of them are housekeeping proteins, and it's like we don't need to modify them at all. If there's too much or less, it's just not going to work. But the estimates are we have of all of the ideal targets for pharmaceuticals, we only have about 10% of those that we can actually modulate their amount with a pharmaceutical. Okay? Which means that we should have, at minimum, conservatively, 10 times more pharmaceuticals than what we currently have. And yet we don't, and again, it's because this goal is very, very hard to accomplish. Because, anyways, it's not a matter of is it useful, it's a matter of is it profitable, right? Yeah.
All the donations that go to like foundations and stuff, that doesn't apply to this? Where does the money go?
It depends on where you're giving. Unfortunately, you can usually pull the tax documents of any of the nonprofits and figure out how much the people that work for those nonprofits get paid. But a lot of it goes to administrative costs. People's salaries and then other administrative costs. And very little of it actually goes to doing anything. Plus you're talking about, it costs tens of billions of dollars to take something to market. To get it through the process, take a pharmaceutical to market, is tens of billions of dollars. There are very few nonprofits that are bringing in tens of billions of dollars in donations.
Wait, why does it cost that much?
Because it takes a lot of time, and it takes a lot of research, and it takes a lot of people, and it takes a lot of paying people to look the other way for some things. It's just the reality of how it works.
That's excessive.
The average time it takes from from the time that you develop a drug to where it actually gets to market, the average time is 17 years. 17 years from drug development until it gets to market. So it's already been developed. 17 years. It's 17 years of clinical trials, 17 years of, paying doctors to use it, 17 years of paying doctors to do clinical trials. I mean, it's expensive. And then that doesn't count the time it takes to actually develop something. So 17 years of people's time and energy is expensive. Yeah. I mean, 17 years of my time is very cheap. I'll do whatever you want for the next 17 years for... we could sit down and we could talk about how much, but I think it would be shockingly low, the amount of money that I would talk about. Oh, you couldn't have all of my time for the next 17 years just for Taco Bell. I mean, I could feed my kids Taco Bell as well, but you need other things to stay alive. Yeah.
I was talking to a professor at Loma Linda, and she made like a leukemia drug in research. She said it was going to cost $2 billion to get it just to chimp trials in the FDA.
2 billion? Yeah. Yep. It's ridiculous. I mean, it's just very, very expensive. So the other goal of pharmacogenomics, this one much easier to accomplish and arguably more beneficial, right? Arguably more beneficial is the other goal is to predict the response to a drug based on genotype. And why is this arguably more beneficial? Because then we can take things that we already have at market and we can figure out how effectively they're going to work for these various individuals. So, some things to note. Somebody's individual genotype might render the drug ineffective. We'll talk about how that'll work in a little bit. The genotype might cause some kind of an adverse reaction. 60 to 80% of these adverse reactions are explained by genetic differences. And so that's what you're like, why is that a range? And it's because for some pharmaceuticals, it's closer to 60%. For other pharmaceuticals, it's closer to 80%. And you're like, what's accounting for the other remaining variation? It'd be environmental differences. Maybe gene-gene interaction might fall outside of this as well. Now, these require retrospective and prospective studies. And so basically what you do is you treat this adverse response as a genetic illness. Okay? The adverse response to whatever that pharmaceutical is, you treat it as a genetic illness and you execute either a retrospective or a prospective study to figure out what the markers are that correlate with that genetic illness. So it requires finding specific markers. Most of the time we use single nucleotide polymorphisms for these. And we talked about this before. Microsatellites are nice, but there's just a ton of variation. There aren't very many of them and they're really expensive to find. Okay? And so it's like, all right, we'll use single nucleotide polymorphism. Twist my arm. Why don't you? And this could eliminate adverse effects. As we work towards accomplishing the goal, it could eliminate adverse effects, which really hurt everybody. Because oftentimes when a drug gets taken off the market, it is because of a very rare effect that happens in very few individuals. Whereas if you could anticipate that before you start treating those individuals with it and give them something different, all of the people that are having success with this pharmaceutical would be able to keep taking it. But when something goes off the market, the people that their treatment is going well, they no longer have access to that pharmaceutical either. At least legally. At least with their insurance company paying for it. Right? There are always ways to get what you want. Some of them are just really expensive and aren't feasible. Right? I was going to share a story with you, but maybe another time. Okay? So does this make sense? Okay. You understand why the second goal much easier to accomplish than the first goal? Okay, cool. Because it's going to be an important concept to understand for the quiz that will open up at 11:35. Yeah.
I mean, I kind of get it.
Yeah.
At the same time, you still need people to research it. You still need clinical trials and retrospective studies. It seems like it would also be expensive and hard.
Yeah, I mean, yes, it's not easy, but it's way more doable because you can have a single researcher. Like this person that Nathan was working with, you can have a single researcher study 3, 4, 5 10 drugs that are already at market and set up retrospective studies and find markers that correlate with all of them. And you can have that single researcher do that in maybe 10 years' time. But to get a pharmaceutical from nothing to clinical trials and then to market, that's not going to be accomplished by a single researcher. Yeah, Dan.
What if this one, like finding a drug based on genotype, be more expensive because then you need to have multiple drugs in comparison to just one?
But the reality is, if you don't find those links and you don't treat people properly, the drug is either, at minimum, not going to be effective for some people. That's not great. At maximum, it's actually going to kill people. Really not great, right? So, and the textbook gives a couple of stats. I think it said something like 30% of beta blockers that are used to treat, blood pressure and all sorts of other things associated with cardiovascular disease. 30% of people have no response to them and aren't aided in any way. And then it said 50% of people see no improvement when treated with antidepressants. Now, you could say what you want. Many of those people probably don't need to be treated by antidepressants and need to handle their depression and anxiety in different ways. Sure, but the reality is just there are things that that we can improve and not very expensively. Retrospective studies, when you're talking about like a really popular drug, those are easy to do. I mean, they're a lot easier to do than when you're doing a retrospective study on some rare genetic illness. Like if you're going to try to find the certain markers that correlate with the efficacy of an antidepressant, you can find plenty of people taking that antidepressant and plenty of people not. Those are easier retrospective studies to do. Now, why might somebody have an adverse reaction? And this is where we can get into pharmacokinetic, pharmacodynamic, idiosyncratic. So pharmacokinetic effects. And so here, basically, pharmacokinetic, most of these are going to have to do with how do you metabolize that drug and how long does that drug stick around. So the person might build up excess toxins, and so that's usually going to be fall under this adverse. Although if somebody metabolizes the drug way too quickly and the drug does nothing for them, that would also be an adverse response and would fall under pharmacokinetic. That make sense? But this has to do with how you metabolize the drug or how you distribute it. So a person could have a mutation that doesn't allow them to properly metabolize the drug, so the drug just sticks around, okay? Which is obviously not great. Might not be able to properly distribute the drug, so there might be a mutation in some kind of a transporter that moves the drug into cells that are supposed to make that transporter. But if the transporter isn't being made properly, you might not be able to properly get the drug to the right place. And then might not be able to properly excrete the drug or the metabolic waste from metabolizing the drug. Yeah.
So the CYP gene family
Would fall under this.
right.
Yeah.
Would it have more to do with the first one?
Yes. Inability to metabolize the drug properly. Yeah. Absolutely. Sorry for cutting you off. I got really excited by your question because I knew the answer to it. It was like when I TA'd for biology in high school, and I had to stop sitting in the classroom because I knew the answer to all the questions, and I'd get in trouble from the teacher by answering the questions before she even finished asking them. So then I was a TA for a class, and all I did was sit in the little prep room behind the class and grade. It was depressing and boring. But anyways, it's another story for another time. Due to pharmacodynamic effects, the person might respond incorrectly to the drug. And a good example of this is eliciting an inflammatory response to the drug. And this one's kind of interesting. I thought I'd share this with you as I was writing this. So ibuprofen is an anti-inflammatory. Yes? My brother is allergic to ibuprofen, and when he takes ibuprofen, his entire body swells up. His fingers swell up, his eyes swell up, his lips swell up. To an anti-inflammatory, does the exact opposite of what its intended function is.
Nice.
I would say it's funny, but that would be wrong. but it's pretty dang funny. He doesn't take ibuprofen very often, as you might imagine. So, yeah, a good example of this. Another example of this could be that, let's say you've got a fairly common disease, but your cause of that disease is different than what is typical, right? And so, I don't know. Let's think of an example. Let's just go with diabetes, right? And so there are a number of different things that might lead to improper levels of insulin production. Okay? You might have issues with being able to determine what blood sugar levels are and be able to respond properly by producing and releasing the right amount of insulin. You might have an issue with making insulin. You might have an issue with actually secreting insulin. You may have an issue with the cells binding insulin. There might be plenty of insulin, but the cells don't bind it properly. And so you might have an adverse effect because you basically target a protein that isn't an issue. And so you target a protein lowering its amount or lowering its functionality, and that wasn't the issue. And then so you have an adverse effect because you're like, oh, they must have a mutant copy of this protein. Let's give them basically a drug designed to shut down that. And that wasn't the problem all along. So the original problem continues, and then you have kind of an adverse effect by shutting down a protein that was functioning just fine. Wow, just fine. I hiccuped in the middle of that sentence. All right. And then due to idiosyncratic effects, the expression of non-target genes might influence the response to the drug. So this is where you have a separate gene that's impacting the expression of the target gene, or that target protein, or the expression of the non-target genes might be influenced by the drug because those genes might be impacted by the target gene, or by the protein of that target gene. So here's where we've got gene-gene interactions. And of all of these, the idiosyncratic are the hardest to anticipate. As a healthcare provider, you usually can do a pretty good job of anticipating what would happen if the person can't properly metabolize the drug, right? And you usually have a pretty good idea of anticipating what would happen if we're targeting a protein that's not an issue in this person, right? Or what would happen if this person happens to be allergic to the drug. But it's very difficult to anticipate what would happen if there's some kind of a gene-gene interaction going on. Because one, it's hard to find these gene-gene interactions, and two, is even when you find them, it's hard to exactly know what all of the implications of that are going to be. So these are some of the hardest to anticipate. Okay. What's that?
I'm sorry, can you repeat? The reason why it's hard is because it's hard to find it.
Yeah, it's hard to even find all of our gene-gene interactions. Really difficult. Especially in humans, because the best way to find gene-gene interactions is to do knockout experiments, but you can't do those on humans. And so it's really difficult to find those. And even if you know some of them, it's really hard to anticipate what it's actually going to look like. Even if you know that there's some kind of epistatic relationship between two genes, it's still hard to understand what the implications of that are going to be if you start impacting one of those genes. So, yeah.
The expression of a non-target gene influencing the response to the drug, does that usually result from just us not knowing that those interacted with each other?
Yes. Yeah, and so what this would look like is you may have like a non-functional protein, but it might not be because that protein is structurally wrong. It might be because the expression of the gene for that protein is being shut down by another gene, right? And so this would be one where you're like, okay, it's typical that when people have this genetic illness, they have one mutant copy of this protein and one normal copy of this protein. And so you target a pharmaceutical to basically minimize the amount of the mutant copy versus the normal copy, but that might not be the problem all along. They just might have a low expression of that because of a second gene. And so really the only way to treat it would be to know what that second gene is and to treat that second, now develop something for a new target to then get that downstream effect. But then it's just like, okay, well, sometimes you just have to move multiple genes down the road until you find the real culprit. And then you're like, okay, well now we know if we start modifying the expression of this gene that it's going to impact these 10 other genes, right? And then now you've got these idiosyncratic things that are hard to predict exactly what's going to happen. All right. Oh wow, just all of them right there. There we go. That's sad. Where are effective biomarkers? Where are our effective biomarkers? Which basically another way to ask this question is, where are the portions of the human genome that correlate with the response to pharmaceuticals? And most of them are in the CYP genes, that gene family. And so I already mentioned this, these genes code for proteins that oxidize endogenous compounds, things that we make, but also xenobiotics, some foreign material, especially pharmaceuticals, things that you take to change your physiology in some way. Markers in this gene family alone account for 80% of all known adverse drug responses. And so here's how this works a little bit, some of the mechanism. So someone might have a fast-acting variant of this gene. And then so what happens is they metabolize the drug too quickly, and the drug never has a chance to reach its target protein. And so what you find is there, in those individuals, you just have to give them a ton. So I have a fast-acting variant that metabolizes Novocaine. So when I go to the dentist, I have to get like 5 times the dose of what a normal person my size would get. And you're like, there's no normal person your size, Dr. Eagle. I understand. No, this is America. You're wrong. Lots of Americans are my size. And so I have to get an enormous amount of Novocaine because I metabolize it way too quickly. Which is fun when you discover that as an 8-year-old boy. Yeah. So, sad. You're like, why didn't you brush your teeth better? That's on you, Dr. Eagle. I feel no sympathy. So the individual might have a slow-acting variant that metabolizes the drug way too slowly, and so you get the drug building up. And when drugs build up, they end up in tissues that they shouldn't be in, and which then creates unnecessary and unwanted effects. Okay? And then someone might have a non-functional form. And so 35% of humans, this is estimated, 35% of humans are a carrier for a non-functional version of this gene. If you had 2 non-functional versions of this gene, you probably would not survive. Because you would build up all of these metabolic waste that you normally do a good job of destroying, and then you don't. But if you are a carrier for it, you're probably going to see some kind of a change in how you metabolize the drug. So a good example of this, CYP2C9. This is one specific gene in the CYP gene family, and it correlates with warfarin. So you can have a fast-acting variant that metabolizes warfarin too quickly. And warfarin, by the way, it's the active ingredient in rat poison, and it's a clotting inhibitor. And so when you feed it to rats, it does a wonderful job of getting rats to bleed to death. But when you give it to people that have a tendency to have like clotting issues, people with like atrial fibrillation, where you've got a weird arrhythmia and then it causes you to throw clots a lot, it keeps you from forming clots. Anyways, warfarin's kind of disappearing off the market for a number of reasons. But anyways, so this gene, you can have a fast-acting variant that metabolizes it too quickly, or you can have a slow-acting variant that metabolizes it too slowly, and you'd lead to too high of a concentration of warfarin. There's another genetic marker that correlates with warfarin, and that's in this gene, VKORC1. and it explains actually more of the variation than CYP, and it's one of the exceptions to this. Most are in the CYP. And I don't know exactly what this gene does, but it's somewhere involved in the metabolism of this, of warfarin. And then the last marker that I want to share with you, right as time expires, is we have a transporter on epithelial tissue that's coded for by the gene ABCB1. And so mutations in this gene make it very difficult for you to absorb pharmaceuticals. And so it makes you what we call multi-drug resistant. You can't absorb them, right? You take the pharmaceutical, it's in your intestines, you don't absorb it. You just poop it out. And it's gone. All right? That's it. We're out of time. We actually went 1 minute over, I'm sorry. Actually, we didn't according to that computer, but we did according to this computer. So I don't know what's right. I'm going to say we didn't. Oh. You say we went over, I say we didn't. I'll give it to you.